Fred Smith. I'm Clinical Director of the Proton Therapy Service at the Christie Hospital in South Manchester. And I'm going to talk to you about the National Proton Therapy Referral Network UK experience. We've had a proton programme since 2008, initially overseas, but we do have a facility now in Manchester, and a sister centre is due to open in London later this year. So I'm going to talk about the practicalities of referral, how the service has developed over time, and then bring you up to speed with what's happening in the present day. So I'd like to thank the organisers for asking me to speak. So what are the criteria for patients offered proton therapy? Well, there needs to be a clear indication for radiation therapy, a good overall survival, and no life-limiting comorbidities. The performance status needs to be relatively good, although with the advent of the service in Manchester, negating the need to fly abroad for treatment, this threshold has been a lot more flexible, as we are able to take patients who require inpatient care, who are recovering from surgery, for example. There also needs to be no evidence of distant metastasis, although there are some notable exceptions to this. Patients are eligible under one of four categories. The first route to access protons is routine commissioning, which is age and diagnosis based, and this is based on NHS England policies, which I will talk about in the next slide. Patients can be eligible for enrolment in a proton clinical trial. A number of trials are in development, and we have one open study at the moment, which is the Torpedo trial. Patients may be eligible for treatment under evaluative commissioning. Essentially, these are phase 2 single-arm studies looking at the outcomes and feasibility of treatment with proton therapy, and this is usually for small groups of patients, especially rare tumours. And there's also eligibility under small volume registry studies. So, for example, patients post solid organ transplant. And again, I'll talk about this later. I've talked about routine commissioning and NHS England's policies. They have a number of policies, both positive and negative. A positive policy is encompasses those patients that would be routinely offered proton therapy as a modality of treatment. There are also a number of negative policies where there is insufficient evidence, and therefore a particular indication may not be routinely commissioned. However, it does open the door to the development of proton trials, and I give some examples there, but I could add others to the list, such as a breast study, which is in development. And there are mechanisms for referral and assessment across the UK, and policies are aligned across the devolved administrations. So this is just an overview of what the routinely commissioned indications look like. This will not come as a surprise to many. This would be regarded as fairly standard internationally. The paediatric and teenage young adult policies are principle based, so it's not just about having a particular diagnosis, but age is a big factor, and the potential benefit from having protons over standard X-ray therapy. There are also a number of adult indications, mostly head and neck, as well as dose escalation cases such as chordoma and chondrosarcoma. The Republic of Ireland also has a similar list. So what's been the NHS England approach to commissioning services? Well, since a number of patients will have rare cancers and complex treatment pathways, it was felt important that providers had their clinical services and patient support in place to expertly care for these patients, and to have the appropriate age and based support services in place, as well as the other aspects of infrastructure that you would expect. From a technological point of view, and certainly in commissioning the UK-based centres, multiple treatment rooms with fully rotating gantries, with advanced imaging capabilities, delivering intensity modulated proton therapy. So as I've said, the NHS Overseas programme has been going since 2008, and the NHS funded treatment, associated medical costs, travel, accommodation and insurance. There have been a number of overseas providers over time. Jacksonville and Essen, I think, have probably taken the largest proportion of patients, but Oklahoma, Paul Sherry Institute, as well as other providers have also provided care to UK patients. The Christie opened its doors to treating patients in December of 2018. It is a facility that is on sort of 3 main operational levels and has 3 gantries for treating patients, as well as a 4th research room. So the provision of proton therapy for NHS patients has evolved over time, with initially the overseas programme, as I've mentioned, to today, where we have the Christie as well as the overseas programme. Obviously, with the impact of COVID-19, much of that overseas capacity has not been available to us, and it's really only recently that patients have begun being able to go abroad to Essen for treatment. Later this year, UCLH, our sister NHS provider, will start treating patients with proton therapy, and by 2022 we should have full capacity across the service in place and little reliance on the overseas programme, if any. We've used a referral portal which has been operational since December 2018 for managing the referrals into the service. It's a Christie developed and managed interface, and it is cloud-based to enable access to those in the devolved nations, and referral to allocation time to drop significantly, and I'll come on to that later. The referral portal has many functions. The referrer creates and submits a referral. A national panel assesses eligibility. Commissioners then approve the treatment or not, and then the allocated referral, if approved, and all of the associated data is transferred into the provider's electronic health record. The portal handles both structured and unstructured data. The structured data aligns with our Proton minimum data set, and I'm going to talk about outcomes in a later talk, and unstructured data such as operation notes, radiology notes, histology, etc., etc. And so all of that data is available for analysis. It's probably worth saying that all referrals since 2008 have been migrated onto the platform. The referral portal is an integral part of the digital pathway, and I'm going to expand on this later, where essentially patients are referred through a digital platform which is web-based, and that information is then fed through into the clinical systems of the providers. This is actually some snapshots of the refreshed portal interface, and you will see the various flavors available dependent upon the role of the individual that's logged in. So the referrer, the panel, the commissioner and providers will see slightly different interfaces which are specific to their roles. But whichever role you log into, it is all about referral of patients for proton therapy, and essentially the patient referral is split into 4 parts, as you will see here. We have got the sort of patient demographics and some details about the general practitioner and also the team looking after that patient, and also some questions about language needs and whether the patient can be contacted. Then we come on to the sort of substantive part of the referral, which is the history section. And there are a number of questions, all aligning with the minimum data set that's been developed for protons, which covers the patient's history, as well as other support needs that they may have. Do they have any endocrine problems, for example? Have they got any metalwork or prosthetic material in place? How have they handled general anaesthetic in the past if they're a young patient? All of these things are very useful for providers to know, and we need to ensure they're captured in a systematic way so that there are no surprises when we see the patient in clinic. And then there is a section which has the unstructured data in it, and these are the clinic letters, MDT discussions, and reports, and the like. And the fourth panel is very role specific. So this happens to be the commissioner interface. And as you'll see, there are some panel opinions given here, and the commissioner has the ability to record their decision whether to approve the case or not. So what about programme activity? Well, since 2008, you will see that the numbers of patients referred have grown and grown and grown. And we have had, well, now over 2,853 referrals to date. And you can see the breakdown of age and sex there. Some of these referrals are second referrals regarding the same patient, and that's why these two figures don't tally exactly. And these are the sort of allocation statistics. And as you'll see, the Christie has seen a fair number of patients to date, despite its existence for only a relatively short space of time. Jacksonville, by far, given its many years of service to UK patients, has seen the greatest proportion of patients for proton therapy. This is another way of looking at that year-on-year increasing activity. There was a little spike in sort of 2015, and this was the introduction of a new clinical policy, which was more expansive in terms of paediatric and young oncology indications. But despite there being little in the way of introduction of new policies over time, the number of referrals has just increased year on year. And obviously with the opening of the Christie service, we saw a spike also, as some patients who were not able to access treatment overseas are obviously now able to, as they don't need to take flights, etc., etc. You will also see here on this overview graph the impact of COVID on referral activity also. As mentioned, the Christie opening did impact on the overseas programme, as you can see here. So the Proton Overseas Programme allocations per year, and the NHS or Christie allocations per year. And as you see, since the opening in late December, the Christie has increasingly taken over the lion's share of referrals sent through for consideration of proton therapy. This is our activity as a programme year to date. It's for all age groups, and these are by the various devolved administrations, as you would expect. The greatest majority, just given where the population lives, are from England. Obviously, it has been a year tainted by the COVID pandemic, and we've had a number of frameworks in place and standard operating procedures where we have not been treating certain groups of patients with proton therapy, preferring treatment locally with photons. We still have the second framework in place, although this is due to be relaxed shortly. By referrer, you can see the statistics here. It's probably not a surprise that there's obviously a little bit of a halo effect having a proton centre on your doorstep, but these figures proportionally tend to represent the activity by referrer year on year. How long does it take to make once you've made a referral into the portal, for the the panel and the commissioners to make their assessments. Well, those statistics are shown here. For paediatric patients, the average duration from submission to provider allocation is 6.88 days. And for all patients, that does rise slightly to 9.6 days. It probably represents the fact that for the adult patients who have tended to have very complex journeys, getting to the panels tends to take a little bit longer in their decision making, and tend to be, certainly where dose escalation is concerned, not as urgent as some of the paediatric referrals we receive. What does the future referral process look like? Well, it's fair to say that the referral base is increasingly knowledgeable about eligibility and the pros and cons of delivering proton therapy to particular patients. I think it's also fair to say that there is increasing expertise at the proton centres. Also, it's not just ourselves who've been operational for some years, but UCH has had some time to prepare for the opening of their service, and obviously been watching closely what has been happening in terms of the operation of the service in Manchester. And also referral activity is set to significantly increase in the future. You know, the UK-based capacity is increasing with a further 3 gantries. There is an anticipated expansion of indications, as well as a significant increase in the number of proton trials being conducted. The only proton clinical trial open at the present time is the Torpedo study, which is a study looking at the treatment of oropharyngeal cancer with protons. But of course, any patient that's enrolled within a proton study is going to be pre-screened during the trial enrollment process, as trials obviously come with inclusion and exclusion criteria. So the plan is, when UCH is fully ramped up, for the national panels to stand down. And it will therefore be the role of the provider MDTs to make both the commissioning and the clinical decision. Given the increase in activity and all that I've said above, it's important that we have a more efficient way of handling referrals. We currently have a referral portal secretariat who manually allocates patients to providers, either to ourselves, who have first option of taking those patients, or through to an overseas provider if we have insufficient capacity, say, for example, general anaesthetic capacity and the like. With the increased number of referrals, and to reduce those turnaround times, it was felt that some form of pass-through functionality would be needed, especially as the national panels are standing down. So as soon as a referrer submits a referral, the referral is allocated to the relevant provider by catchment area, as long as that referral satisfies certain rules. So for the Christie, what will our catchment look like? We're going from a pan-UK and, during COVID, Republic of Ireland service. We will focus very much on the North and Midlands of England, Scotland, North Wales, Northern Ireland and the Republic of Ireland, as well as the Isle of Man, which sits in the Irish Sea. UCLH will cover the south of England, South Wales, the Channel Islands, the Isle of Wight, and the Falklands, and other overseas dependencies. So what does pass-through or auto-allocation look like on a sort of, in terms of the referral portal interface? Well, you can see here, it primarily affects both the commissioner and the provider interface. The commissioner creates indications, which obviously initially will just reflect the current indications that we have and already hard-coded into the system. And they will say whether the indication is active or not, and the indication type, whether it's routine, trial, or evaluative commissioning or whatever, and what age groups that particular indication is commissioned for. And if pass-through is enabled, then it will appear on the provider screen, and it's for the provider to say whether they can accept patients on pass-through in this manner. This is important. If there is an issue with a particular provider's service, so for example, if the cyclotron has issues or there are problems with severely restricted capacity because of gantry, multiple gantry problems, then it actually enables us as a provider to switch off pass-through, and we've got protocols and pathways in place for what happens during those contingency measures. And so in this way, we can balance the referrals coming into the service and those against our capacity. So I talked about future activity increase and talk briefly about trials and the like. UCH is due to open this year with a significant increase in additional capacity. Given our experience, the current routinely treated indications will account for approximately 30 to 40% of projected overall activity at both centres. And there is therefore significant residual activity available for trials, evaluative commissioning and registry type studies, as well as expansion in routine indications. So what does the future look like? Well, there is going to be some expansion in routine indications, pediatric and TYA lymphoma, neuroblastoma, Wilms, and high-risk medulloblastoma. We've been working on those protocols for some time, and we'll have the capacity in place to treat those patients. Adult craniospinal will also be added to the list of indications. And there's also a rationale for proton therapy outside the current indications list, for example, rare tumours, the post-transplant and the radiation-induced second malignancy populations of patients. And there's also proton clinical trials and evaluative commissioning studies, which will account for the majority of our activity at full ramp-up. So what does that trial and evaluative commissioning activity look like? Well, CT-RAD, which is a national research body, has been overseeing the development of proton therapy clinical trials, and also has been reviewing evaluative commissioning study proposals, and this is in concert with the National Health Service. We have a number of clinical trials in development. As I've mentioned before, the Torpedo trial is already has been open now for some time. But we've got a number of other studies in advanced development, and we're in ongoing discussions with the trial management groups there to ensure that they're implemented in a smooth way, not least the alignment and collection of outcome data, which CTUs will do on our behalf, and I'll come back to that in the second talk I'm doing today. We've got a number in setup and a number in advanced development. And we've also got, in terms of the pipeline, a number of trials in early development also, so a lot of this could change. In terms of the evaluative commissioning studies that are in development, you'll see here that we've got some head and neck studies, hepatobiliary pediatric, as well as lymphoma studies that are being developed. So, in summary then, I'd like to thank Professor Adrian Crellin, who is the NHS England clinical lead for proton therapy, who very much helped me in putting together these slides. But before I go on to the summary of the referral network itself, just like to draw your attention to a shameless plug of the Christie Proton Therapy eSchool, which is starting a few weeks away. And if you're interested in hearing about all aspects of proton therapy, there's lots of clinical cases as well as the basics of proton therapy. So if you're at all interested, then get your camera out and get a link to book your place. So in terms of the referral network, there's been an NHS England programme since 2008, and that has taken referrals from the 4 nations of the United Kingdom, dependencies, as well as the Republic of Ireland latterly. And that relationship looks set to continue, hopefully. It is the largest series of whole population equitable access to protons linked to outcomes globally, and I will talk about that later. The Christie commenced service in 2018, and UCH is due to open this later this year. In the past year, the Christie has been allocating 95% of all UK patients needing proton therapy. A referral portal was implemented at the same time as our opening, and this has enabled more timely turnaround of referred cases to allocation. With better quality information, and the referral portal data feeds into both UK providers' electronic health records. So that sort of kickstarts the outcome data collection journey for us, and we can actually pre-populate our forms with that data, so we don't have to duplicate entry into our systems. The referrer has done that already for us. Over the next year, UCH is going to be an additional provider, and there will be a significant uplift in activity with the increased indications, whether that be routine, evaluative, or trial. And the trial patients will account for the great majority of our activity at full ramp. There are going to be some significant changes to the way the national panels and referral portal operate. So the next year holds a lot of change for the service. Well, I do hope you found that talk useful and interesting, and thank you for your time.